Hello, everyone. I'm John Lynn, the founder and chief editor at Healthcare IT Today, and I'm excited to bring you another in our series of interviews with top leaders in health IT. Today's guest is Dr. Anil Jain. He's Chief Innovation Officer at Innovaccer. Welcome, Anil.
Well, thank you, John. It's great to be here and talk about such an important topic.
Yeah, so the topic du jour, maybe it is for me because I'm headed to a interoperability conference next week. But before we dive into that topic, tell us a little bit about yourself and Innovaccer.
Yeah, hi, I'm Anil Jain. I am the Chief Innovation Officer at Innovaccer, and in my role, I help our organization with our product strategy and where we make our investments for the innovations that we see around us. Innovaccer is a big data healthcare analytics platform company that is designed to help organizations, providers, payers, and life sciences make the most use of their data and solve some of the thorniest problems that they're dealing with in healthcare today.
Yeah, there's a lot of thorny problems. So it's important. And they're all built on the back of data, let's be honest. But how would you describe where we're really at when it comes to healthcare interoperability today?
Oh, I think we're still in the early stages. I think we've done a pretty good job over the last 20 years in knocking out some of the technical requirements for information to be interoperable in the fact that we can send bits and bytes, and at least we know what those bits and bytes represent. I think we've got a long way to go for the semantic aspects of interoperability, where what I mean is something that you can comprehend regardless of where you're at. A simple example would be when I practice, and I'm very part-time these days. I'm an internal medicine doc, and my focus when I use the letter CP would be chest pain. But if I have a neurology colleague across campus or across town or maybe across the country, and I use those same exact letters, CP, they might think I'm referring to cerebral palsy. So it's simply just being able to transmit the letters C and P and having someone be able to assume that that's a diagnosis is not enough. We need a level of understanding that needs to happen in healthcare that is still somewhat elusive. We're getting there, but we still got some distance to go.
Yeah, I was talking to someone recently about also trusting, like, where did that come from? And do I trust that person that it came from? It feels like that's part of it as well. And maybe if I had that information, I would know that CP came from internal medicine. And that means, chest pain versus, a neurologist who would say cerebral palsy, right? I mean, that seems like the other piece, like, okay, I got the data, but do I really trust it?
Yeah, I think what you're alluding to is the context matters and the metadata around the data matters. If you are transmitting a diagnosis related to the heart, and you know that it came from Dr. Jain, a primary care doctor, versus Dr. Lin, a cardiologist who may have seen that particular condition 1,000 times, you're more likely to trust it. Or that it came from within your own health system, or that it came from a provider and not a payer. These are just examples of where the
Or from a
provenance of the
patient.
or from the patient. There are some studies that folks can look up where they ask patients things like, when was your last colonoscopy? And there's a segment of patients who don't remember getting a colonoscopy. So if you were to ask them, did you ever have a colonoscopy? That level of trustworthiness may be a little bit off. There are things that, depending on who generates the data, where the data comes from, how old the data is, all sorts of things that we have to consider when it comes to being able to interpret the data to take action.
Yeah. So what are some of the big areas where healthcare organizations are really asking you to help with interoperability? What are like your top use cases?
I think most of the health systems today have some degree of being able to technically get data from their systems and use it. Where we get a lot of questions being asked is, well, I've got several different electronic health records, perhaps within their own system. Across a community, they might have affiliate providers who are all engaged in some sort of risk-bearing contract for value-based care. Can you help bring all that disparate data together and create a single view of an individual patient or member so that we understand what the next best action might be for them? And that requires everything from knowing that Mr. Smith, who walked through the emergency room door, is the same Mr. Smith who got hospitalized last weekend, is the same Mr. Smith that needs a follow-up, all the way to understanding that there's going to be redundancy in the data, there's going to be gaps in the data, and how we sort of create a 360-degree view of the patient is something that they're asking us to do. They're also asking us to get the data ready to be analyzed. It's one thing to be able to exchange data, John, but it's another thing to be able to say, I've got the data in a way that's clean enough that if I now start to analyze it, I'm going to be enabling someone, empowering someone to take an action on it. Everything from removing erroneous data all the way to really going through and seeing whether we can, again, that semantic understanding of the data. Do the codes translate into something meaningful?
Sure. Well, and the duplicate data becomes a real problem if you're analyzing it, right? Because it could double the same stat.
Yeah, one of the biggest challenges is that when you start to bring in clinical data from multiple different providers and hospitals, and you start to then layer in claims administrative data from health plans, how do you create a single view of what happened during an episode of care?
Same incident.
Otherwise, did they really get 2 chest x-rays, or was one chest x-ray from the clinical record and one chest x-ray from the billing record, etc.?
Yeah. Well, and sadly, they probably would get 2 chest x-rays sometimes. So
well, yeah, if there isn't interoperability at, working at scale in a community, we often will see redundant care being provided because simply the information was simply not available to the ordering providers, for sure.
Yeah, it gets complicated to do that. So that makes sense that they want you to help with that. What do you think's maybe still holding interoperability back, that you'd like to see maybe from the vendors that are holding the data? We hold up the EHR vendors, but there's hundreds of other systems too, right? What's really holding interoperability back from happening?
Yeah, I think one of the things that I've recently started talking to our internal teams and to our clients about is the concept of intraoperability, meaning, we really can't have true interoperability between systems, between providers, when we don't really have intraoperability within a health system or within an organization. We often see problems just connecting 2 different systems together within a large health system. So one of the things that Innovaccer does is we try to bring all that data from within the health system together in order to create a single view of what might be the source of truth within that organization. Then you have an opportunity to actually start to share information across constituents, across stakeholders, and have a single source of truth at that level. So one of the first things that we do is we try to create a common data model, or at least bring in the data in a common way, and then understand who's who in the zoo, who should be able to see the data of a certain type and who should not. We sort of focus on understanding the data provenance and the data lineage so that when data does come together, we understand exactly what the constraints might be when we try to make decisions. So what's, I think, holding us back in many ways is that the tools and technology that often helps health systems with their basic block and tackle, whether it's revenue cycle, whether it's HR, they all speak different languages. And every time you come in to try to integrate or to bring that data in an intraoperable way, the goal is to not lose any kind of fidelity from those systems, which means that it's not just the data, but all the metadata that surrounds it that we have to understand. So one of the challenges is that there is no Rosetta Stone in healthcare for all the different parts and pieces. And really understanding and making sense of the data requires us to really understand how the data got in there to begin with, understanding workflows. What were manual workflows? What were automated workflows? Do we understand how data drifted over time? Do we understand how data drifted from one regulatory pressure to the next? So there's a bit of sort of data inspecting, if you will, in the early days of any of our engagements to help organizations basically overcome the simple reality that intraoperability does not exist in health systems today. And some of the emerging standards are helping for a subset of data, but there are no specific data models or terminologies or ontologies to represent much of the business of healthcare that our clients are asking for help for.
Yeah. What's interesting about the intraoperability is that that's easier from a privacy and security standpoint than the interoperability, where you need to know the identity, you need to know if there's accepted. Whereas within the same organization, do you still see some of the same challenges in protecting the information, or is that easier?
Yeah, in some ways, I think when you have a regulatory scaffolding to sort of stand on, some of those things might actually be easier from a governance point of view. We have HIPAA, we have very clear guidelines as to what is considered to be sensitive or not sensitive, and what is considered to be PHI and what is not. And we have rules around what data can be shared across participants to avoid things like Stark and anti-kickback statutes and things of that sort. Where I think it gets a little bit more complicated is when you believe that there are no restrictions from a regulatory point of view, and you just expect a machine that is outputting information from one system to simply just be put into another system and not expect that there's going to be some artifact from the workflows that might vary in a significant way. So although regulatory barriers do provide a complexity, I don't think that it's as much of a barrier for well-established, experienced companies who are helping organizations, as much as just understanding what people do in their organization that drives the data into their systems. That change management, that workflow aspects of it makes interpreting data much more difficult than making sure that we help our clients comply with HIPAA and things of that sort.
Yeah, that's a really interesting perspective on the regulatory frameworks and the benefits they can have. So that's interesting. Now, you talked a little bit about interoperability standards. Do you think that the standards we have today are enough? Are they going to eventually fall short? Or are they falling short? It sounds like maybe you feel like they are of kind of the desired interoperability goals.
Yeah. No, I think it's great progress. No doubt about it. I think that we need a set of standards that helps all of us at some level be able to exchange information and have some level of understanding of it. But if you try taking the complexity of the human condition and the complexity of human disease and try to boil it down to ICD-10 codes, or try to boil it down to the fact that there is clinicians like me who are incredibly busy, especially these days, who are putting information in and driving documentation. It's no wonder that it's probably a good start, but it's not going to be sufficient for the real problems that we're needing to tackle. That's why it's important to think about extending the standards with the ability to use natural language processing and natural language understanding. Why it's important to look at that data across the spectrum and see whether there's artifact being introduced. Is every patient with a certain condition being coded in the exact same generic way, or is there granularity that helps us understand what's really happening with patients? So I think it's the standards around diagnoses and medications. I mean, the FDA's done a great job with creating NDC codes, and others have jumped on with creating RX norm and all the variety of different proprietary codes. But at some point, we do need to have a much more level playing field when it comes to crosswalks. If I get a code of one form, do I have unreasonable barriers to now convert it to another form that we as taxpayers have already paid for through the National Library of Medicine or through others? So I think it's great to have standards. The crosswalks, I think, need some work, and then being able to make sure that we all understand that the human condition requires way more granularity than what may exist today.
It's fascinating to see you apply it that way. I think it was a decade ago, a doctor wrote and taught me about the need for clinical decision support. And the argument they made for it was that the complexity of the human condition, as you described it, right? And also the massive medical knowledge that's out there is beyond what the human brain can do. And so that was his argument for clinical decision support, that, we're great. We do amazing things as humans, right? But there's just so much out there that we need technology to help augment what we're doing there. It's interesting to see you apply that to interoperability, and that, hey, we may never get to, full interoperability, or we'll need technology to supplement that, right? Like you said, NLP or whatever it might be, to manage the significant complexity that's there, which is why I hate any comparison to financial interoperability, right? Like, it's just so much easier compared to medical. Anyway, so it's interesting to see you apply it that way.
John, you bring up a great point. I mean, I think the idea of clinical decision support in some ways is the verb of interoperability. If the noun is me just being able to share some information with you about an individual, that's great. But if I want to share all the different actions that we might want to consider doing on an individual, we need to broaden the lens of interoperability and talk about how do I make all the things that I do as a doctor, all the things that I do as a clinical informaticist, all the things that I might do in working through healthcare, how do I make and expose all those different possible opportunities in an interoperable way, so that it's not just exchanging information, but exchanging what actions can I take, and how can I share my thought process with the next person who picks up this medical record. That part of it is something that clinical decision support, again, is getting more and more advanced every day, but we're still somewhat elusive. I want to be able to, and what clinicians tell me is they want to be able to exchange not only medical information with the next doctor or the next provider, but also how do they arrive at the decisions that they did in treating the individual? How do they now translate that from a clinical language into a lay-friendly language for the patient to be able to understand at home? As we move more and more into consumerism, interoperability is not just about me communicating with another provider across town, but it's about me also being able to communicate better with the patient, and the patient being able to communicate with their healthcare information wherever they want, whenever they want, and then be able to share that with whomever they want in order to get the best possible care. So that clinical decision support kind of raised, in me at least, this idea that we ought to be able to make the data much more actionable than it is today, which is, again, we still have some work to do as an industry.
Yeah, absolutely. So where do you think we'll be in interoperability in 5 years? Luckily, you're not a publicly traded company, so you can look to the future. So how about 5 years from now? Are more of the same? What's your prediction?
Well, I think there's going to be a greater acceptance that interoperability is no longer a burden on providers in order to comply with interoperability rules or standards, but that it becomes a way, a sort of a way to accelerate the value that providers may be giving each other in an ecosystem, the way that providers and payers may try to eliminate some of the burden that they both have. For example, prior authorization seems to be one area where patients, providers, and payers could all benefit if we simply had widely accepted interoperability. And I think it's moving very, very quickly. Other examples of clinicians making the right value-based care choice for their patient because they understand what the prices are, they understand what the quality and the value that will be delivered. All that requires a degree of interoperability. Within 5 years, I think we're going to start to see movement where payers and providers and those who innovate in the industry, like life sciences, may start to have some things that will be mainstream, like I think prior auth will be a very different beast in the future. Much of it will be automated through standards, through interoperability, through trust. If I trust information, I can make the appropriate automatic adjudication. And I think there'll be some experiments where providers and life sciences and payers start to use the basics of interoperability to be able to have a shared understanding of what's happening with their member, their patient, their customer, and be able to have a lot of things that are low risk and where everyone can trust and create common agreements be automatically adjudicated without some of the nonsense that we deal with in the industry today. So 5 years, I see a lot more automation through interoperability. I see a lot more guardrails that will enforce more trust. And I see business models that will leverage that increased interoperability.
I think every doctor that listens to this just is going to let out a collective wahoo and hope your prediction about prior auth is right. Because
well, I don't think we have a choice. I think it's one of those things which really drives everyone crazy. I'm sure there are ulterior motives that some folks may have for having it, but there's a general agreement that the way it's done today is unnecessary and it just hurts the patient.
Yeah. I think what's interesting, though, about this discussion is just kind of describing the shift in dependency on interoperability. We saw this in the EHR world, right? Where they shifted to the EHR and now they use the EHR's clinical decision support. They use the order sets. They use all of this. And then when the EHR goes down, they're like, oh, dang, how do I see a patient without the EHR? who's going to give me the order set and give me the past history and everything that they depended on. That's almost what you described. It sounded like, that now we're going to be dependent on the interoperability to provide the value-based care, to provide the, even the prior auth, approvals to be able to do it, which it's interesting that whole dependency. And I can hear a clinician one day saying, I can't believe the interop's down, right? Like I can't,
Well,
how do I see a patient?
Yeah, no, it's a great example. I see it as a zigzag pattern where when we start becoming more dependent on a set of workflows, then the vendors, including us, have a higher need to be more reliable and more up for their customers and constituents. If the ATM system was down for 5 minutes, it would wreak havoc. At some point, the ability for healthcare applications to talk to each other in an interoperable way will become a requirement that it be up all the time, that there be redundancy built into the system, that vendors build it in a cloud-based way that allows there to be a full dependability. We're not there yet, but it's a bit of a zigzag. When we get closer to that, then there'll be more reliance from our end users. And when the end users have more reliance, that will drive the vendors to be more reliable, and so on and so on. But other industries have already gone that way. If a travel site is down, to be able to buy tickets or book your travel, which we recently did across the country, never left the application. The application did it no matter what airline it was, no matter what hotel chain it was. It was all done within the single platform. As we become dependent on that, I think the vendor community will rise to the challenge, and customers will expect it, and then we will hopefully, as a industry, it will become so basic that we'll be looking to the next value driver, as opposed to thinking about how to connect within a health system and across health systems, different pieces of technology.
Absolutely. Well, thanks so much, Anil. This was a really thoughtful look into interoperability and a fun look into the future as well. And thanks everyone for watching and listening. If you want to find more great healthcare IT content like this, be sure to check it out at healthcareittoday.com or search for Healthcare IT Today on your favorite podcasting application. Thanks so much, Anil.
Well, thank you, John. It was great fun.